Okay, welcome out everybody. We're going to go ahead and get started. We have got a jam-packed presentation tonight. We are going to be talking about some intermediate level cases today. So a little bit more difficult than what I usually show in a first presentation. We're going to try and get some intro stuff done in about 10 minutes, giving a quick review of doing a quick review of osteoperforations and vibration, and then we're going to hit some cases hard. We're going to do some moderate to difficult cases, and we're also going to do some interdisciplinary cases. I mentioned, but for those of you that come in late, I mentioned before, I do have a Facebook blog called Acceleration Ortho Station. This is a great place to post cases and ask questions, and we can come together as a community to advance accelerated orthodontics. So feel free to join that. It is limited to orthodontists and orthodontic residents. A little bit of a disclosure here. It is captured on the video, so we are now moving forward. This is my family. Always like to show them and why I do things. Got 5 children. My twins are 17, an 11-year-old boy, a 9-year-old girl, and a 6-year-old boy. We're getting excited for the Christmas season and ramping up for that here in Arizona. It's a little bit cooler today in Arizona. We got down in the 70s, but we've been 80 all week, so I'm happy to be here in Arizona. So let's talk about acceleration biology. There's a few things that we can do in order to move teeth faster. There's pharmaceutical approaches, which really haven't taken off in orthodontics. Electromagnetic stimulation, another one that no one has probably used. Cyclic forces or vibration. Now this is something that's been in the literature and in the case reports lately. A few different products that can put a vibratory force on the teeth. Propel has one called the VPRO 5, which works very nicely for aligner seating. There's laser or light out of Vancouver. There's the BioLux, which is recently on the market, which we can see some literature about that. Laser, I think, is up and coming. There may be some cheaper ways in order to deliver that to our orthodontic patients in the future. There's ultrasound. This technology is out of Alberta, Canada. Some real interesting stuff there. But these things that the first 3 that I've talked about are a little bit more expensive to deliver to the patient, the vibration being the cheapest of the 3 that I've shown. There's surgical stimuli, which is the Wilckodontics. That's where we lay a complete full thickness flap, expose the cortical plate of the bone, and use a high-speed handpiece to make cortical incisions in the cortical plate. And we'll actually show one of those cases real quickly. Now, if we don't want to lay a surgical flap, there's another way in which we can deliver a cortical injury, and that's with the Propel driver by doing a manual osteoperforation or a MOP, numbing up the soft tissue either with a topical gel or with local infiltration, and then putting a surgical grade stainless steel screw directly through the soft tissue and then 2 millimeters deep into the cortical bone. These screws are not very expensive, and it becomes a very economical way of delivering what, in my opinion, is the gold standard of accelerated orthodontic tooth movement. All of these have a common theme, a biological mechanism known as RAP. RAP stands for Regional Acceleratory Phenomenon. All that means is that cellular cascade of events that occurs with the initiation of tooth movement. When we get the RAP response, by whatever means we deliver it with, we get a influx of the cytokines, those communicators that communicate with the osteoblast and osteoclastic mediators to help the bone remodel faster. Again, these chemical messengers are called cytokines, and when we get more of those flooding into the area, we call that RAP, or regional acceleratory phenomenon. So we get a cytokine response, creating the cells to do all kinds of fun stuff. which ultimately culminate in the creation of osteoclasts and osteoblasts, or more of them, to help remodel the bone. Well, the theory is if we do a micro-osteoperforation or a MOP, we increase the inflammation in the area where we did that. We increase the number of cytokines, therefore the wrap, and therefore increasing the rate of the tooth movement. All this has to do with bone remodeling, resorption, reversion, formation, and mineralization. So again, micro-osteoperforations increase the inflammation, increase the number of cytokines, therefore the rate of bone remodeling and the rate of tooth movement. So if we want to move a tooth faster, we've got to change the rate at which the bone remodels around the teeth. And Propel MOPs are a way in which we can do that. So even if you push harder, that's not going to cause your teeth to move faster. Constant, slow, steady force is what we want, but what we want to be able to do is through MOPs be able to change the rate at which the bone remodels around the teeth. I first got my start in this with Wilckodontics. This is one of my first Wilckodontics patients. This gentleman came in to me and he had had an ATV accident, and his jaw was in all kinds of different positions. You can fractures all over the place, bone plates all over the place. And the problem that he had was that he really needed a surgery in order to fix the bite. This is the way the ENT put him back together again. But as he went into the oral surgeon complaining that his teeth didn't fit together anymore, the surgeon was reluctant to redo the surgery. So he sent him over to me and asked me, is there anything that I can do? And I was concerned that these were very difficult tooth movements to make, and so we discussed doing Wilckodontics, and that's what we did. Well, what's the problem list? He's got an avulse number 7, number 8 and 9 are ankylosed, number 10 has a vertical fracture and is non-restorable. Number 11 has a fracture above the gum line, but is restorable if we can extrude that tooth. In avulse number 25, a cross bite on the left, an open bite on the right, and according to him, he had a perfect occlusion before the accident. So what do? Well, we do some Wilckodontics. We lay a full surgical flap, and we make cortical incisions between the roots of the teeth in the anterior and in the posteriors on the upper. We place some bone grafting over in this area because of the recession, some bone grafting in the lower anterior. The treatment plan is going to be to close the space on the bottom, extrude number 11 so that it can have crown lengthening and be restored, and then an implant in number 7, an implant in number 10, take out 8, 9, and 10 and do a 4-unit implant retained bridge, 7 to 10. So that's the idea. So here we are with the braces on in the bottom pano. We're going to use ankylosed 8 and 9 as anchorage to kind of move things around, and we've got the wrap response because of the Wilckodontics in which we did between some of the roots of the teeth. Well, in just 13 months, this is what we were able to accomplish. We were able to completely close the avulse number 25 site. We were able to extrude number 11 so that a root canal could be completed, and we got the fracture down far enough that with crown lengthening we were able to get a good biological width so that that tooth could be saved. Just recently, before this picture, I took the braces off in the morning. The patient went to the oral surgeon, had some implants placed, and then a 6-unit bridge overlaying the implants while the implants integrate. During this time, I'm still going to settle the occlusion over the next 3 or 4 months while the implants integrate, and then the final restorations will be placed. But as you can see, in just 13 months, we were able to get the space closed, get the open bite closed on the side, get tooth number 11 extruded, level out the bite in the front, get some expansion on the left side, and the gingiva looks much better on that side. You can see the implants placed and the 6-unit bridge while everything's integrated. Here he was initially, and here we are when we're done. And we just got a fabulous result. Now, this is a case that I would have thought that we would not be able to get this type of result, but not only did we get it, we got it in about a year. And because of this and other cases very similar to it, I grew a passion for accelerated orthodontics. Now, here it wasn't about just doing it fast, it was about doing the impossible, right? Or what we feel like is impossible. So one of the great things about accelerated orthodontics is it's not just about finishing faster. In my mind, it's about finishing better and faster. Well, what is Wilckodontics? Well, we can see in this first corticotomy picture that we lay a full thickness flap and we make cortical incisions in the bone using a high-speed handpiece. Whereas with the Propel, there's no flap needed. We can do that in the office. It's relatively inexpensive, and we just stick the screw directly through the soft tissue and make dimples directly into the bone. One of my theories is that when we place these screws into the bone, we get radiating microfractures out, that radiate out to about 5 to 10 millimeters, and that's how we can get the response to spread with just a few perforations. So I think that that's a great advancement in orthodontics. There's a few different modalities in which we can deliver these micro-osteoperforations in the mouth. My favorite is going to be the electric driver shown there on the right, the accelerated PT or power tip, which has disposable screws unique for each patient, specially designed surgical grade stainless steel screws to do the micro-osteoperforations. Well, in rats, we can see these perforations were done. We've got a control, no orthodontic force at all, orthodontics alone. Orthodontics plus the perforations, in the same amount of time, the tooth was able to move twice as far. The reason why is because when we make these micro-osteoperforations, what the histology shows us and the staining shows us is that we get the yellow bars here are the orthodontics plus the perforations. All these are cytokines. We got twice as many cytokines in the areas where we did the micro-osteoperforations. So that's the reason why we're able to move teeth twice as fast. If we look out on a CT scan, we see the control, we see orthodontics alone. With the perforations, we can see all the osteoclastic activity on the leading side, and then all the osteoblastic activity on the trailing side. So the bone remodels twice as fast with osteoperforations. In the AJODO, and I'm quickly summarizing these studies, obviously, because we got a lot to get to. I just want to give some basic, very basic background. In the AJODO, we've got a study where at New York University where they did upper first bicuspid extractions. In this particular case, on the right, it was orthodontics alone. On the left, it was orthodontics plus the MOPs, the same force on both sides. And then just 4 weeks later, the tooth has moved twice as far on the study side where we placed the micro-osteoperforations. And in that study, they measured a 2.3-fold increase in the rate of the orthodontic tooth movement. By using gingival clavicular strips, they were able to measure the cytokine expressions. In this case, the black bars are the orthodontics plus the MOPs, and each one of these are different cytokines, and they were increased by at least twice as much, which is why we believe that the teeth are able to move twice as fast, so a 2.3-fold increase in the rate of orthodontic tooth movement. So in January 2010, when I implemented Wilckodontics, I had great clinical success, but I had difficulty getting a lot of patients to do that. In 2013, I've been doing this almost 5 years now. We had great clinical success, but because the procedure was so easy to do, pain with the minimal amount of pain to the patients, because it's relatively inexpensive, 70–80% of my adult patients now accept this procedure when it's offered to them. So what do? Well, we palpate the tissue, evaluate the externary. We're going to have them rinse with chlorhexidine, and then we're going to anesthetize and accelerate. I like to place 2 micro-osteoperforations in between the roots in which we're going to move. So review that x-ray, stay away from any vital structures, and then you're going to choose your anesthesia. I like to use BTT, which is a compound anesthetic with prilocaine, tetracaine, lidocaine, and phenylephrine. If you use this in a systematic manner, you can get great anesthesia and you don't have to use the needle. One of the things that I've heard just a few people, I've had probably 3 or 4 phone calls about it over 3 or 4 years, is because of phenylephrine, sometimes patients can get headaches because of that vasoconstrictors. It's very, very rare. In over 400 cases, I've only had one of these. But the to counteract that, it's nice to have some caffeine on hand, either a Coke, a Diet Pepsi, or some Goodies headache powder, because the caffeine can help counteract the vasoconstrictor with the phenylephrine. Now, of course, if you're comfortable using the needle, using Septicaine 4% with epinephrine is a great way in order to get anesthesia. Also, just point and shoot, real easy to do with the local infiltration also. But we don't just put it on with a wooden Q-tip just like this. We have a methodical approach for placing topical. I cut little gauze strips in half. Here we see a perfect length for 5 to 5. On the bottom is the perfect length for 3 to 3. We put some gel in on the strip. We don't want to overdo it because it is, you know, a compound topical, and we don't want to overdose the patients on too much of this stuff and give them the headache. So just a small strip of topical in a controlled fashion. Make sure the trach retractors are in. So we want to make sure the tissue is dry, cut the gauze to size. We want to remove it after 3 or 4 minutes. Wipe it away first. Don't just spray it all over the mouth. Wipe it away first and then have the patient rinse. Allow at least additional 10 minutes before you do the procedure. So rinse it off, then wait 10 minutes. This is critical, that additional 10 minutes. Do not be impatient. If you rinse it out after 3 minutes and get going, the patient will be numb. So give them that good 15 minutes before you get started with the procedure. So this is me. This is the most numb I've ever been in my life. Got my upper 5 to 5 strip on, my lower 3 to 3, and when we took this off, I was completely numb. One of my buddies did Propel on me. He was able to get me super numb, and here we are. And he drove the driver 7 millimeters deep into my bone, and he was even able to let go, and I wasn't feeling a thing. Now this is deeper than I usually suggest people drive the screw. Usually we only need to go 2 millimeters into the cortical plate of the bone. So that means 2 millimeters for soft tissue, 2 millimeters into the bone. So of that 7 millimeter screw, we're only going to be needing 4 millimeters of it. But here it is, and I was feeling fine. In fact, an hour later, we were out eating ice cream, and I can definitely see how patients could have a good experience with this if they only have to do this once or twice, and if they're going to finish twice as fast, they're going to love us for it. So this is one of my first experiences using Propel. We don't have sound on the video, I don't believe, but I just twisted it in and able to have a conversation with her. So I set the device to just 3 millimeters, and 1 millimeter for the soft tissue on the bottom, 2 millimeters through the cortical plate, and she wasn't feeling a thing except just a little bit of pressure. So you can make this happen quite comfortably for the patient. Here we are with the electric driver, placing micro-osteoperforation. Here we're going 4 millimeters deep, 2 millimeters for the soft tissue, 2 millimeters for the cortical plate of the bone. We just go in 2 millimeters and then back out, and it's just real easy to place these micro-osteoperforations. You can tell on the patient's eyes she's not feeling a thing, and she's very, very comfortable. So it's a great way to deliver this cortical trauma to get the rapid response. Now sometimes the bone can be a little bit more difficult to penetrate, and so I put my thumb on the head of the driver and my forefinger on the opposite side of the alveolus. The pressure is nice to reduce some of the discomfort for the patient, and we just hit play and reverse, and the assistant is standing there with gauze so that she can wipe the excess blood away, which in this case there's not that much, and she only does it about once every quadrant. So I'll go from the back to the front, and then when we get to the midline, she'll come through and wipe the area clean of the blood, and then maybe drop a strip of gauze in order to control the rest of the bleeding when we go to the other side. So again, this is really easy to do, and I've got plenty of webinars. There's other people with plenty of webinars to get more into the basics of this technique, but I really want to get going forward into some of the more difficult cases. So this is what the perforations look like. We want to aim between the roots. We want to make sure to get a above the crest of the bone. I like to do 2 to 3 micro-osteoperforation between the roots in which we want to activate. Here's that same patient that I showed you on the video. We did 2 perforations, one above the mucogingival junction, one below. I set the device to 3 millimeters. On the lower anterior, 1 millimeter for the thin soft tissue and 2 millimeters into the cortical plate. 2 weeks later, you can see that she's healed just fine, and then I'm going to have her start changing her aligners every 3 days instead of every week. Here the MOPs are initially. Here we are after 4 weeks. Here we are after 6 months. We can see that the holes are starting to heal over. So I repeat the procedure about every 6 months if we still need it. Keep in mind that I very, very, very rarely repeat the procedure because we're usually done in under 6 months. It's only under some of the more difficult cases where we're detailing still in months 7, 8, 9 that I might come through and do a couple of those procedures. And we'll show a couple of those cases tonight because it's December, it's the end of the year. We want to show some of the more difficult cases. So 3 days per aligner is my protocol for how quickly I change the aligners after I make sure to get 2 perforations in between the roots of the teeth that we're going to move. And so here we are at 23 trays, changing the aligners every 3 days, and we're able to align those bottom anterior teeth very nicely. In the upper 2 had 43, and we were able to finish this case in just 4.5 months, and she had some elastics for sequential distalization also. So let's show some real quick cases with 3-day aligner changes. Here we've got a lower midline shift, we've got an ectopic canine, lingualized, and we've got a little bit of a deep bite. We were able to resolve most of those issues. Got the canine uprighted, got the midline pretty close to center. That's actually how I set it in the ClinCheck, so it ended up exactly like the ClinCheck, and we were able to open the deep bite just with a few perforations. 3 distal of the canine, 3 mesial, 3 mesial of the lateral, and 3 mesial and distal of this canine on the left. And just in 4.5 months, we were able to burn through 35 aligners at 3 days per aligner and able to finish this case. Some difficult laterals there on the bottom. We're going to do 2 perforations, upper and lower 2 to 2. Here we are when we're done. We're able to get those difficult laterals uprighted and get everything lined up just nicely in just 6 months of treatment with 36 aligners at 3-day aligner changes. The diastema closed with composite. We're going to remove that composite, do some IPR. Here's the day we removed the rest of the composite. We did the IPR on the lower, and we were able to get the space closed quite nicely. And from the middle picture to the bottom picture, that was just 19 Invisalign trays. We were able to close all that space in just 8 weeks at 3-day aligner changes. Anterior crossbite, so we're going to do a little lower IPR down here. A little IPR up here, and we're going to do the perforations just on the teeth here that are circled. So that's where we place our MOPs. Here we are when we're done, a nice occlusion. 27 aligners at 3 days per aligner. We were able to finish this case in just 4 months at 3-day aligner changes. A little bit easier of a case, some minor crowding. Here it is when we're finished. Just 8 weeks completion on this one with 14 Invisalign trays at 3-day aligner changes. Another rogue lateral down on the bottom. We're going to do propel lower 2 to 2 and upper 2 to 2. Here we are when we're done. We did 3-day aligner changes. We had 29 aligners, and we were able to finish this case in 5 months. Here, this one's a little bit different. We did propel lower 2 to 2 for this lower relapse. She, as a youth, had second bicuspids taken out. They relapsed back open. I didn't treat this case initially. Now she's an adult. She gets retreated. So what are we going to do? We're going to do 2 perforations, mesial the 6, mesial the 7, distal the 7 on both sides to help protract those molars. No propel in the front, just in the molars and lower 2 to 2. Here we are when we're done. We were able to get the molar spaces closed, get the bottom lined up. Now she's my orthodontic assistant. I asked her to change the trays every 3 days, but like any good orthodontic assistant, she doesn't listen to me. So she changed them every 2 days, and we were able to get this result in just 8 weeks with 2-day aligner changes. A little deep bite, so can it help us expand? Well, I put 1 perforation between the bicuspids and then 2 perforations, upper and lower 2 to 2. We're able to open the deep bite, get a little bit of expansion, resolve the lower crowding. This was done with 21 aligners at 3-day aligner changes, and we were able to finish this case in just 3 months. Another deep bite here. We got to do a lot of expansion. So here we're going to do 2 perforations, micro-osteoperforations, upper and lower, 6 to 6. Here we are when we're done, able to open the bite, able to get the expansion, able to resolve the crowding. This was 35 aligners. We were able to finish this case in 4 months utilizing Invisalign and micro-osteoperforations. Well, this one's a little bit different, not quite as complex. We're going to try and expand the upper a little bit, resolve the lower crowding. Here we are when we're done. We got a ton of expansion. I mean, if you're someone that likes a lot of expansion, we got it. The only thing I wish I would have done is maybe done some IPR for the dark triangles, but we did this one a little bit different. This time we did 21 aligners, and instead of 3-day aligner changes, we did 5-day aligner changes, and we finished in 4 months. The reason why I did 5-day aligner changes is this time I didn't do the micro-osteoperforations. Instead, I used the vPro 5. The vPro 5 is a high-frequency vibration device that operates at 120 hertz, and we're able to use this to seed the aligners. So I have the patient put the aligner, eat their last meal of the day, brush their teeth, put their aligners in, have them use the high frequency vibration for 5 minutes, and they do that every night. And then my protocol is to have the patients change their aligners every 5 days when we're doing the high frequency vibration aligner seeder. The reason why is because the vibration seats the aligners so well against the teeth that it appears to me that things seem to track better, and therefore I change the aligners every 5 days. I've done probably now over 200, 250 of these cases at 5-day aligner changes every time without any problems. Here's another case. This gentleman works overseas. He works overseas for 4 months. He comes home for 3 months. Anyway, he came home. He came to see me right away. He said, "Is there anything I can do?" I said, "Well, let's get you lined up." So we expedited the Invisalign case. We got the aligners back. I gave him his aligners. I gave him a vPro 5. Had him change the aligners every 5 days. He came back in 4 months, and this is his completed result using the aligner seeders to vibrate the aligners in position. So Propel gives us some great options in order to get great results with our patients. So here's a patient, one of my first patients with Propel, and this time we're going to be reactive. So this patient was congenitally missing some first bicuspids. She was missing tooth number 4, tooth number 20, and tooth number 29. And what I thought would be cool would be to go ahead and take out tooth number 4 also. I may have said 4 before, so she was missing 13. We took out 4. And what I don't want to do is bring her upper front teeth back. And with all these spaces that she has in the front, if I just throw a power chain in the bottom, the lower teeth are going to fly back, the upper teeth are going to fly back, and we're going to dish in her face and get an anesthetic profile. So what I really want to do is protract all the molars, burn that anchorage, and bring the teeth forward. So I thought that would be a great idea. I'm going to use indirect anchorage, so I'm going to place the tabs on the top, use a power chain on the top to close those spaces up, and elastic to the bottom. Well, here we are after about a year, and I'm not getting very far, and we've switched in between power chain and elastics and started doing some power chain and things too, and we're just having a heck of a time. So I decided maybe Propel would help us out. One of the things I want to show you is this recession was here before we got started. It'll be there after we're done. In fact, I think this improves just a little bit after we do the Propel. So anyway, after a year, we're starting to struggle, so we do the Propel in the extraction sites, mesial and distal of the molars. Also, 1 month since Propel, we're starting to see some changes. 2 months since Propel, now we're really starting to get those spaces closed. So for a year we were really struggling. Then once we started doing the Propel, that got everything to kick into gear to get things moving. 5 months since Propel, finally we've got the spaces closed, but the molars have tipped forward. So now what I'm going to do is take off the standard prescription bands that I have. So you can see this band here is changing. What this hook here is a power arm. This is an Andrews bracket, a T3 bracket, which has some extra mesial inclination in the roots to help upright those roots. So I put T3 brackets on the top and the bottom. You can see here I was transitioning into that T3 bracket to help upright the root. So it took me 5 months to get the space closed, and then another 5 months to get the roots upright. And here we are when we're done. We're able to get a nice occlusion, and if we look at her profile, we didn't lose any of that anterior anchorage. Everything came forward and nice bone, and the posterior also, the roots are nice and upright. So we use Propel to help us get out of that bind. Initially, for a first year, I couldn't get it closed. Then we do the Propel, and things started happening rapidly. How about an upper extraction site? Now, I wanted to do an implant on this kid, but he didn't. He wasn't having it. He says, if you don't close it, I will never close the space because I'm never getting an implant. I said, okay, give it a try. The only problem is he wanted Invisalign. So closing that space with Invisalign creates some issues. So we had an approach to getting that closed. So now we're getting into some really fun, crazy stuff, right? So what am I going to do? Well, I'm going to do Propel almost everywhere, and then I'm going to, so here in the anterior to resolve this crowding around this molar, and then lower 3 to 3. I'll show you the perforations in a minute. So what I'm going to do is place a TAD here to get direct anchorage to bring that molar forward. Well, we had an unfortunate problem. I'm placing the TAD in, and here you can see my TAD. Wait, here's half my TAD. It's in the bone. Here's the other half of my TAD. It broke off. So I often have people ask me, oh, I just use my TADs in order to place micro-osteoperforations. Well, I've had this happen to me twice, and that's enough to let me know that TADs are not suited to do micro-osteoperforations because the titanium break. If we're going to go in and out, in and out, in and out, in and out several times, you don't want to have this happen to you because that's a trip to the oral surgeon. And if we're using an off-label device, FDA-approved device for an off-label purpose, you see TAD is FDA approved, but it's for the placement of a temporary anchorage device, not for Propel. So we don't really have much of a leg to stand on if we're using the TAD and something goes wrong. Anyway, so I sent the patient to the oral surgeon because the TAD was well in there when it broke. So the oral surgeon removed the TAD for me and placed another TAD in for me. Instead of the TAD being here, he placed it here instead, and then we're going to use direct anchorage to bring it over. Well, he placed the TAD in for me, and then after the patient came back, we had everything settled in from the TAD. Then I come through and I place the micro-osteo perforations lower 2 to 2 here in the upper anterior, and then in the congenitally missing tooth space. And apparently I did some in this area between the 3s and the 4s also. Anyway, we're protracting that tooth using partial mechanics. Now, before the TAD broke, I was going to do this a different way, but because the TAD was placed a little bit further back, it kind of limited my approach on what we were going to do. And so this is what we ended up with. Initially, 2 weeks later, the tooth is really coming forward because we did the Propel. 2 months after Propel, now the tooth is really coming forward. But you can see here, I didn't have braces on, and I didn't have anything to prevent it from tipping. I guess I can show my cards. What I was really going to do, I was going to place a TAD here, place a TAD here between the 4 and the 5, and then I was going to use a T-loop in order to bring that forward with the wire going through the 2 TADs down to the T-loop. But when this TAD broke, I could only put 1 TAD in, and this was no longer a good place to place a TAD because of all the inflammation it probably would have felt, so I was stuck with 1 TAD. So I tipped it forward, which was not ideal. You can see how it tipped forward. Then I added braces onto the 4s and 5s and worked into a 20 by 20, untipped the tooth while continually moving it forward. So here we are at 3 months. So, and here we are 5 months after Propel. We've worked our way through 55 aligners in this time. We were able to get the tooth forward, but it's not quite uprighted yet, but it's looking better. And now we're going to bond some buttons on the lower to do some settling elastics in order to bring that tooth in. So we did new MOPs in order to help those teeth settle into position. So are we going to do MOPs down in this area down here? No, we're not. We want to do the MOPs up in this area because these are the teeth that we want to settle. So I added more MOPs up in this area at the about 6 or 7 month mark. You can see it's 7 months starting to settle, 8 months even better, 10 months. I'm going to call this done because now we can't settle anymore because of the Invisalign tray. So now I just need to take the Invisalign tray out during the day, and I think that the rest of this will settle in on its own. So at 10 months, we removed all the appliances. We were able to get the root uprighted, get the extraction space closed, and we're going to rely on his body to do the remainder of the settling, which it eventually did, I believe, a few months later. So he was pleased that he didn't need to get the implant. Here's an extraction case. So I know a lot of people ask, well, how do we do extractions with braces? So this is going to be a full braces case. You can see here that she can barely touch her lips together. I have, she's a dental assistant. I have begged her for a year or two to have jaw surgery. She's not going to do it. And so we're going to take out bicuspids, maximum anchorage, and bring some things back. There's going to be a few compromises along the way. She'll probably get a little gummy, but we're wanting her to be able to get her lips together better, improve the profile somewhat, realizing that with extremely good informed consent, she has decided she's never going to do the jaw surgery. So we take out the upper first bicuspids. You can see she's already a little gummy here. Anyway, we get the braces on, we take out the upper first bicuspids. Is this the time to propel? The answer is no. I once was asked to be involved in a study on extraction cases and propel, and they'd already started some extraction cases, and what they had done is they had extracted 4 bicuspids, and on one side they did propel, and on the other side they didn't. Well, that's already going to be a bad study because we already have a RAP response from the extractions, so we don't need to do propel right away. We've already got the RAP response. So the study in the AJODO, where they did the split mouth study of the upper first bicuspid extractions, they took the bicuspids out 6 months prior to treatment, and then they started closing the space. So they took the bicuspids out, let the area heal, and then did the perforations. But you see, if you do the extractions and then do the perforations on one side and not the other, you're probably not going to show any difference because you've already got a RAP response just from doing the extractions. So I do not place micro-osteoperforations immediately after the extractions. Another reason why you don't want to do that is because a lot of times this shelf of bone right here is pretty thin where the extraction was. If you force the propel screw in, you might get some fracturing or significant fracturing of the buccal cortical plate, not microfractures, real fractures. So we don't want to do that propel immediately after the extractions. We just want to start our normal mechanics to start retracting those canines immediately. So I've already leveled and aligned, and I'm ready to start retracting the canines with power arms. These are translation brackets from Larry Andrews. This is probably a T3. This is probably a T1. So it's got some excess prescription in here to keep from tipping the crowns back. But we're going to start that day 1 after the extractions. So here we are 4 months later. You can see because of the RAP response, we're already getting great space closure. 4 months later, we're over halfway there. But 4 months after the extractions, my feeling is that we're going to start to lose that RAP response at about 4 to 6 months. So this is when I come back and I do propel mesial and distal of the canines, I believe, in order to continue retracting those. So you can see here we use the electric driver and we go mesial and distal of this canine to continue to retract the canines back. 4 months later, the canines are completely back into position, so we were able to preserve the RAP response by placing more micro-osteoperforations 4 months after the extractions were done. No TADs were needed in this case because we didn't propel the posterior teeth, and so these act as our anchorage units. Now that we've got the canines back, now we're going to do MOPs, upper and lower 2 to 2, to begin retracting the anterior teeth on a rectangular arch wire. 11 months after the extractions, we began our settling elastics after we get the upper and lower spaces back, and here we are when we're done. She's got a much better profile. I honestly don't think she has to stretch to do that. I think it's more habitual, especially when you see here on the smile. I'll show you some other pictures in a minute. But this is a 1-year 4-by extraction case. We did 2 MOP procedures. So she really had 3 wrap experiences in order to make this happen. The first wrap experience is when the 4s were taken out. The second one was 4 months later when we did propel mesial and distal of the canines. And then the next time was 4 months later in order, at the 8-month mark, in order to retract the upper and lower anterior teeth using relative differential anchorage and no TADs. So you can see the great change that she had in her profile, in her lip posture, and she's just extremely grateful for the non-surgical approach that she had to her malocclusion. So an extraction case with brackets using MOPs to help us. This slide's in the wrong position, so we remember this guy. This is just another view 10 months after we're done, bringing that forward. Sorry, that slide's in the wrong position. So what about lower incisor extractions? So we talked about posterior spaces. How about anterior spaces? Well, this is the problem that I have when we have lower incisor extractions, especially with the liners, is it's difficult to get these roots to come together. So here's a case that was treated with Invisalign. She's a friend of mine, but I didn't do her Invisalign. She had this done before I was an orthodontist, and she had tooth number 25 taken out, and we can see the problems. We've got invagination of the bone. Where we did the procedure, it didn't fill in very well, probably because we didn't get good root proximity, because the roots are still divergent in this Invisalign case. And you can see that she's still got a little bit of a deep bite. So my solution at the time was everything was braces. So I put braces on her, and this was before Propel, and we got that lower incisor uprighted. So this was 14 months of braces. So the first was her result with Invisalign, and the second is the results in 14 months of braces. We're able to get the midline better centered, take care of the bite better, get the roots uprighted, and you can see the difference in the soft tissue papilla and in the invagination of the bone and the quality of the bone once we got the roots in better proximity. So getting those roots in good proximal position is important. But can we do that with clear aligners? Well, as we realm into the world of clear aligners, whether they be Invisalign or whether it's something that we make in our own office, hopefully we have that opportunity in the future. Is there a way that we can do it with aligners and get as good results? Maybe Propel can help. Here's another case with Invisalign, and shows the problem again. He's got a root canal on tooth number, I believe, 26 with an abscess on it. So we're going to take that out, or sorry, tooth number 25. So we're going to take that out, and we're going to place vertical attachments, trying to walk the apices into the extraction site before we close the space. So apices in first with vertical attachments, and then bring the crowns in, hoping to get better root proximity. Let's see how it worked out. Well, it didn't. Without Propel, you can see that we're still quite divergent with some problems with the soft tissue here. So I ended up putting braces on him to solve the problem. 20 months of Invisalign, 2 refinements, still had trouble. So 20 months with 2 refinements. Here we are with 6 months of braces. This is when we're done. He's still got some alginate in this area, but we can see with the braces we were able to get those more upright, and they're looking a little bit better. He's just got to work on his hygiene, I suppose. Well, what about with Propel? Here's a long-standing extraction site. She's got a Maryland bridge that keeps falling off, and she thinks it's ugly, and it's moving in a segment, and this one's getting crooked. So she wants to know if I can just take the Maryland bridge out and close the space. Well, let's give it a try with Invisalign. So we're going to put our vertical attachments on, 20 trays this time instead of 35. We're going to move the apices in first and then tip the crowns in. I don't know if you guys saw that around tray 14 or 15, but let's look at it again. We're going to move the apices into the extraction site first, and then once we get middle of the trays, then we're going to start tipping the crowns in to try and close that space, similar to the previous gentleman that we showed. Can Propel help us? Well, we've got a lot of crowding on the top too, so she's going to get full anterior MOPs. This time we did local infiltration with a needle. That's why the tissue is so puffy right here. One of the things about using a needle instead of the BTT is we inject all this fluid into the gums, you poke the gums, and the fluid comes out. So it bleeds a little bit more if we do the local infiltration into the vestibule. So now when I do local infiltration, I stick the needle right into these areas right here and get the tissue to blanch, and I don't put as much down in the vestibule so that we avoid this puffiness, which creates more bleeding. So here she is at aligner 17. We're able to completely close that space with just some small little spaces here. We're going to do 3 overcorrection trays to really cinch, virtual C-chain trays to really bring this lower spacing together. So I ordered 5 more trays to close that space up. We only used 3 of them. So here we are when we're done. We had 20 aligners total, and we had 51 days. So after that bloody picture, this was exactly 51 days. At 3-day aligner changes, we were able to get those roots nice and upright. We know that we were able to get good translation of the roots because we can see where the bone is remodeling right here. This is all osteoid. This is going to recalcify all these dark areas and turn into real nice solid bone. But we can see how nicely the roots translated in this case using Propel to help us because we can tell by this black line where the bone hasn't recalcified yet. So here's a year follow-up. We can see that that bone recalcified just fine, no problems, and it's stable, and everything still looks really nice, even a year and a half after treatment for her, which was the last time that I saw her. We snapped this x-ray. So just 51 days to close that extraction space. Well, here's another one. You got to be able to do it twice or it's not believable, right? So this is Sid. He comes in, he's got a dark triangle, so we're going to do IPR for the dark triangle. We're going to do composite buildups, mesial and distal of the twos. We just got to distribute that space, and we're going to remove this composite Maryland bridge and close this space similar to the last case. So here we are, we've done the IPR, we do the Propel, and now we're going to close that space. 31 aligners, vertical attachments. We're going to move the apices of the roots into the extraction site before the crowns, and mid-treatment we're going to start to tip the crowns into the area. 31 aligners this time in order to get him ready. So here we are at, I believe, aligner 31, and well, no, this is mid-treatment. Here we are at aligner 31. So now I'm sending him over to the general dentist to get some more composite placed. So we're going to do the composite bonding on the laterals, and we're going to place a little bit into the remaining of this dark triangle here. Now the root's not completely upright here, but I just left him in that last Invisalign tray for about 3 or 4 weeks while he went to get the composite done. And when he came back after getting the composites placed, just a little bit of extra time in that last tray, that tooth completely uprighted, and this is our final result, closing the lower extraction space and reducing the dark triangles. We were able to finish this case in just 6 months, closing that lower incisor space. You can see here where it was taken out. Now the roots are nice and upright, no tipping in, using Propel to help us close the lower incisor space. Now, I want you to know that when I do these lower cases, I try to get at least 2 perforations here. If I can, I try and get 3, because remember, we want those apices to be activated so they can really tip into those extraction sites. Well, Sid got a great result. He wrote me a nice little Google review. He says, Dr. Shipley came highly recommended by my surgeon. As an adult in professional setting, I was reluctant for ortho due to look and length of treatment. They did a great job, cutting edge orthodontics. He recommended Propel. I couldn't be any happier. Instead of 2 weeks between changing the Invisalign trays, it's only 3 days. This accelerated the 2-year treatment plan into just 6 months. 4 times faster in his case. The results were truly amazing. So we were able to get a nice little Google review because he was so happy with his result from the micro-osteoperforations. How about some interdisciplinary cases? Well, this gentleman comes in and he's just a mess. He's got severe wear, and for various reasons I need to get this case finished in 6 months. So let's plan it out. A lot of times in these wear cases, because the teeth become skinnier and get pushed back in the face, they really get pushed back in the aesthetic zone, and we have this denture looking appearance to the smile. So all austere, we want to measure the gingival margins and the papilla and draw out some templates of how we want the teeth to be. So we want to intrude those 3 lower incisors to coincide with the other. So we want to get a little bit of intrusion of these upper teeth to level the gingival margins. And then we want to intrude these 3 teeth here in order to get those gingival margins leveled, so the rest can be completed with restorative. And let's keep moving along here. So we need to get the teeth longer and wider. So we put the braces on. I do Propel, upper and lower 3 to 3. We're going to level those upper gingival margins, so the wire should coincide with the upper gingival margin, so that when that levels out, we level the gingival margins, and then we'll intrude those lower anterior teeth. Just 3 months later, we've got the intrusion we needed. Now we just need to put springs in order to open spaces between the anterior teeth. 6 weeks later, he comes back. We've got plenty of spaces between the teeth. We take the braces off in the morning. We send him down to the dentist to get the temporary composites done. They're longer and wider. I'm going to put braces back on, so the dentist didn't need to close all those spaces. He just needed to make the teeth the right length and width. Put the braces back on in the afternoon. The teeth look much better in repose. Now I just got to close the rest of the spaces, get a little bit more intrusion. And here we are when we're done with the ortho. So the dentist put some composites here to show me where to put the overbite, and some composite here on the bicuspid. He wanted to show me where to set the overbite because he was going to put some crowns in the back and replace these ugly composites with new porcelain. And we were able to get that done in just 7 months. Here he is with his temporaries on. And here he is with his final restoration. So a nice interdisciplinary case using Propel in order to get the production back faster to the general dentist. The general dentists don't like it when we as orthodontists keep these cases for 2.5 years, because they like money too. They want to do great work, and that's why they refer them to us. But they also would like to get paid eventually. And as you know, as an orthodontist, sometimes when keep a case for 2 years, by the time that 2 years is over, the insurance has changed, the dentist is different, they moved on for whatever reason, and the dentists oftentimes end up losing these cases. By using Propel to finish these cases faster, we can get the production back quicker to the dentist, and trust me, they will appreciate that. Here's another case that we didn't do Propel on. Here, she didn't like her lateral incisors. She said they were too wide and too pointy and too humpy. Oh, that's just a joke. Of course, she's missing number 7 and number 10. She wants me to open space for implants. The roots aren't helping us any, and she wants to have Invisalign. So I do Invisalign for her, and it takes me 3 years and 2 refinements. And during that time of Invisalign, she's got pontics in these areas, but she has to take her teeth out in order to eat. So she doesn't eat socially for about 3 years. And so it's been a rough quality of life for her because she doesn't like taking her teeth out. When she puts her teeth in, she has a real youthful appearance. When she takes them out, not so youthful. So anyway, 3 years, we were able to open the space, get the roots uprighted, got the implants placed, and she's real happy with the results. How much happier could she have been if we were able to complete this case in 9 months instead of 3 years? So let's try it again. This gentleman comes in and he wants implants for his missing laterals also, but this time we're going to do Propel. He's got a lot of crowding down here too, so we're going to do Propel all over the mouth in order to make this happen. His roots aren't helping us. We really got to create some space in between there. So I like to place, if I'm just doing one perforation, I like to place it in the attached gingiva right above the mucogingival junction, because the centers of rotation generally coincide with the mucogingival junction. So if we're going to activate a tooth, we typically want to do it around the centers of rotation. Well, I typically like to place 2 perforations. So if we're going to do 2 perforations, I like to separate them a little bit. Get one well above the mucogingival junction, one below. You see the center of resistance of the tooth is here, and so we put one up here and one down here to more activate the tooth around the center of resistance. And if we do a bunch of these, this is what it's going to look like. If we have a real long root or a difficult root, we can place a 3rd perforation. Invisalign helps us out because they give us this sheet where we have moderate and advanced tooth movements. So the blue teeth, one of the things that I'll do is I'll take the blue teeth and I'll just right away mark on the sheet, I want to do 2 perforations around those blue teeth. And then an advanced tooth, a real difficult movement, I may want to put 3 perforations for that real difficult movement. I want to also look at the IPR sheet, because where we're doing IPR, those may be difficult movements too. We don't always have to do IPR. Sorry, we don't always have to do MOPs where we're doing IPR, but it's generally a guide of where we may need to put some of those MOPs. Anyway, we put 2 perforations all the way around. Here's that black tooth, so I do 1, 2, 3, and we're going to do 2 perforations on the top in many areas also. 3 weeks later, the tissue heals just fine. 4 months after Propel, we're starting to open up that space. And just 4 months after Propel, look how nicely that lower crowding is getting. Remember, that lower crowding was pretty messed up down here. So we were able to get that pretty lined up just in 4 months. We're going to do a refinement, 9 months total complete treatment time, able to get the space opened even more than we need for the lateral incisor implants. 9 months of treatment plan, more space than we need, able to really get those bottom teeth lined up very nicely with the liners using Propel to help. And then he gets his restorative work done, and still a good job with the porcelain, maybe not quite as good as the previous case, but he's just real happy with the final results. How much better is his quality of life that we were able to finish this in 9 months rather than 3 years? When he's going out with his buddies and eating, he only had to take his teeth out for 9 months, whereas the other patient had to do it for 3 years. So I think that if Propel is reasonable for the patient, it can help increase their quality of life when they're able to finish their treatment faster. You can see we're able to make plenty of space, get the roots nice and upright, get those implants placed. All right, another airman here. Here we've got some peg laterals, another interdisciplinary case. So we've got peg laterals and a posterior crossbite. So what are we going to do? Well, we need to leave space for the peg laterals and get the crossbite corrected. Can Propel help us with the expansion? So I've got elastics on the lingual, on the palatal here, also elastics here. We're going to run a crossbite elastic to these T17 aligners and align the space for the laterals. Well, we use the BTT. Here it is in position. Here you can see the MOPs. Look how neat that looks when we use the BTT. There's not quite as much bleeding when we do the BTT. So one above, one below, one above, one below, one above, same all the way around. And we're going to get those MOPs placed here in the back too to help with the expansion. 2 weeks post healing, everything looks great. Here you can see her crossbite elastics on both sides, because crossbites are usually bilateral. We've got the aligners trimmed around those Kaplan hooks. For those of you that are wondering, I get these from GAC. Part number for curved teeth Kaplan hook, CAPLIN 30-000-06. That's what you want to look for to get these Kaplan hooks. These are for the front teeth. We usually just order the round ones. So here we are, just 10 weeks post-Propel at 3-day aligner changes. We've made some dramatic improvements in getting the crossbite corrected, but we're not quite there, okay? So the question is, well, yeah, I needed longer in the elastics than just the 10 weeks to get this crossbite corrected. Should I have slowed the trays down? Well, no, because the elastics are going to help me regardless of how fast we're moving the trays. So I don't want to slow down the movement of the front teeth just because I'm waiting on these back teeth elastics. So I'd rather do 2 or 3 refinements and really detail the front teeth rather than slow down the trays in the front to wait for the crossbite to be corrected and then do a refinement. Well, that's just spinning our wheels. So we can be more time effective if we straighten the front teeth up and close the space at an accelerated pace. And even though the crossbite elastics are going to take longer, it gives us a chance to do several refinements to really nail in the front teeth. So as we're continuing to work on the posterior teeth, we're going to do a refinement, another 18 aligners to keep getting it just right. And so now we're looking really good, 8 weeks post that refinement. And that was 3 days in aligner. So now we're going to do even a second refinement while we're waiting on this crossbite to get even better. So we order another 18 trays, and we're just continually detailing the front to get as good as result as possible. And now we've got the crossbite corrected, and we've got the front teeth, the diastema closed, and the spaces lined up for the peg laterals. Now all she has to do is get those restored. 32 weeks or 7 months of treatment to get that posterior crossbite corrected. She gets her laterals corrected, and then she got deployed somewhere else, and so thank goodness we did Propel, or else she wouldn't have finished treatment before her deployment. And so now we're just going to let that posterior settle in as she's wearing the retainers. A nice Propel interdisciplinary case where we made space for the peg laterals, and we used the Propel to help us get the crossbite expansion with the Invisalign. All right, here's a fun one. This is one way to close a diastema, right? Just put an extra tooth in there. So this lady went back and forth with a few different dentists with different treatment plans. She's got a bridge here and a bridge here. So our original treatment plan was to section this bridge to help detail this area, put an implant here, and then close the diastema, and then do some IPR on the bottom to retract those lower anterior teeth. So here's her x-rays, here's her PAs, running out of time, so I just got to really run through this. I like to, when I'm working with a dentist, take my iTero scan, combine it with my anatomage, and then we can move the teeth on the anatomodel with the accurate crowns by combining the digital scan from the iTero or the Trios with the CBCT image to get nice anatomodels. I like to send my reports to beam readers to get them to double check for pathology. Once we get the anatomodels, we can get some great images to show the dentist. And one of the ways we can use this is to overlay this facial image, 3D facial image, over the teeth, and we can see here a nice way to look at lips in repose. So here's our lip line in repose, and we can see that we don't see those lips in repose. The incisal edge is right at that lip line. So then when we go to draw our spear templates, now we can draw a line on our PowerPoint slides or on a piece of paper where the lower lip line is. We just trace that line on the previous slide, cut and paste it onto our picture in PowerPoint, and now we know where our lips in repose are. So now we can start drawing our templates. So here's our teeth, here's our lips in repose. We can see we've got the gingival recession up here. with so gingival margins, all kinds of problems with this case. So how are we going to tackle it? Let's draw the teeth out and do a digital treatment plan before we move forward. So here's what our ideal teeth shape would look like. Here's what our actual teeth shape are. Here's her high smile line, and the yellow is her high smile line traced in from the photos also. And so then we're going to draw in the ideal position of the teeth. We want to extrude these teeth and bring them forward so that we show some of the incisal edge in repose, and then we're going to bring our laterals down to match. Well, it would be real great if we could actually do that, but it's going to be difficult to do it. We're going to have to section the bridge, do a lot of things to get there. The patient got the bill from me, the bill from the dentist, and she says, ugh, I don't want to do all that. Is there any way that we can do it cheaper? Well, what if we don't section the bridge? In this case, she didn't want to section the bridge. She wanted to maintain it to save some money. So this bridge is going to be fixed. So instead of drawing it to the incisors first and treating to the incisors, since she's not going to segment this bridge, we've got to treat to the bridge. So now, instead of all that extrusion, we can extrude a little bit, and we've got to retract the anterior teeth to close the space and do lower IPR, because now this bridge isn't going to move. So we want to extrude these teeth and then crown them and close the diastema. Then if she ever wanted to, she could, this will be the final result here, but if she ever wanted to, she could do crown lengthening in the back and have those crowns extended to get a more symmetrical smile throughout. But instead, she's going to end up more like this because it's a compromised treatment plan. So here we can see with our ClinCheck, we're not going to move this bridge. We're going to do IPR on the bottom, and we're going to bring these teeth together using Invisalign. So she had 29 Invisalign trays in order to do that. Let me show the mechanics again. We're not going to move the bridge on the left. We're going to move everything to the bridge, IPR on the bottom to close that space, and then she's got enough porcelain here that the dentist is just going to round out the ledge of the porcelain on tooth number 11. Well, here we are at tray 11, and she's getting pretty bored of 2 weeks per aligners. So now she's asking me, is there any way that we can do this faster? So at tray 11, she says, or tray 10, she says, let's do Propel. So 1 week post Propel, you can see that the gingiva is healed up quite nicely. This is where we did the micro-osteoperforations with Propel. Remember, we've got to retract all those anterior teeth, on the top and the bottom, using the IPR, using the diastema. And so this was at, what, 2 weeks of tray, so 20 weeks into treatment. At tray 19, 4 weeks post-Propel, you can see how much faster the diastema closes. 7 weeks post-Propel, we've got the space closed. But oops, we need to extrude these teeth, right? We want to extrude the gingival margins down to try and level these gingival margins, do some enameloplasty or shorten the incisal edge in the front. So we want the incisal edge to be here, but we want the gingival margin to come further down. So we want it to come here, and then when we do the new crown, we're going to make it shorter. Well, I said we can do a refinement in Invisalign, but really, honestly, I told her the quickest way to get these teeth extruded and get these roots the rest of the way uprighted would just put braces on the front of the teeth. She says, I really want to get this done fast, so if you think anterior braces are going to be faster, let's do that. So sometimes these patients say they're all about Invisalign at the beginning, but in the middle of treatment, once they get to know you better and are more comfortable, they're more willing to take your advice, and a lot of times if you need to, you can get them switched in to braces. So 13 weeks post-Propel, we're getting the roots even more upright, and now you can see that we're starting to extrude. We're repositioning the brackets to get these gingival margins to come even further down. I'm going to go about maybe 7 or 8 more minutes for those of you that, I know I've got you though, I've got your attention. You're not logging out, you love this. Anyway, so here we are at week 17. We did a second set of Propel on just the upper ones only. You can see how far gingivally we've moved these brackets, because we're in this 20 by 29 tie wire. We keep moving the brackets gingerly to extrude these teeth and shaving down the incisal edges as we bring down the gingival margins. Here we are at week 25. We're going to hold it 4 weeks for debo, and then she's going to be ready for her final restorations. So 8 months post-Propel treatment, we've got the teeth extruded, the gingival margins closer to being leveled, and here she is ready for her restorations. So Dr. Osler, one of my good friends and a general dentist, this is what the crowns look like underneath when he took them off, so he had to refine those preparations. You can see he extended where she had the recession here, he extended the temporary crown. Here's the temporaries waiting on the permanents to come back. You can see that we got nice biological width now on those, and we should have some better results. So now we've got some very nice looking crowns on the front. We've got the diastema closed, and she's got a much, much better aesthetic result. He was able to shave the porcelain off this bridge. Not a perfect occlusion where the bridge is. Actually, I think she's not closing down all the way, because here she's closed together. So this picture here in this picture, she's not biting down all the way, but here she is. So a nice occlusion with some nice restorative. So this is how we can use Propel to help us get some nice interdisciplinary cases, to get some teeth to move that would have been difficult to do, and do it in a way, here again, she's not biting down all the way in this picture, but what a nice result for her, done very inexpensively. So real happy for her. So this gentleman comes in and he wants to have jaw surgery, but he is not quite old enough for jaw surgery. So what we do is we take a ceph and we take a ceph and we measure his vertical growth. And I say, well, with your jaw asymmetry and your prognathic mandible asymmetric, because you can see the lower midline here, and you can see how the bottom teeth have tipped in, I tell this young man, I don't want to do surgery yet. Let's wait a year, get another x-ray in a year, and see how you've grown. So here we can see a year later that the green is the initial, the black is a year later, and if you look at some of these measurements, it's probably tracing inaccuracy, but we can see that we've had no vertical growth, and the jaw hasn't grown any further forward because the initial is the green. So after looking at this and doing the tracing, I feel pretty comfortable doing the jaw surgery with him. Well, this was in 2016. It takes him another 6 months to get started for various reasons. So now the Invisalign gives us a ClinCheck, and this is what the first initial ClinCheck is. This is what we want to do, a bunch of IPR to bring everything together and do this non-surgically. No, that's impossible. That's not going to happen, so we got to send it back. What we're going to do instead, still not the right one. What we want to do instead, let me see if I've got the right one here. What we want to do instead is upright the posterior teeth, and then we're going to do one jump at the end, in order to bring the occlusion into position. Okay, so take care of do the surgical decompensations, upright those posterior teeth, and then we're going to show one jump at the end showing the surgery for what we're going to do. Okay, so that's the plan. We're going to do this with Invisalign. So again, looking at this bottom view of that ClinCheck, we're uprighting those lower anterior teeth, decompensating the lower arch where those were tipped in from the crossbite. Let's give it a try. So here we are when we're done with the first set of aligners. So we had 18 aligners. We're going to use the VPRO 5, so we're changing the aligners every 5 days. You see, this gentleman is going to school out of state, and he comes to see me on the break, so he wants to finish as quickly and with few appointments as possible. So how did we do getting these teeth uprighted with Propel? We're trying to upright these. We can see in just 18 aligners in just 90 days, we were able to really get these lower left posterior teeth nice and upright. And now he's ready for jaw surgery. So we do a new scan on this day, and in the office using the digital scan, rather than doing those snap impressions and waiting for the plaster to dry, what we can do is do a new scan and use the Trio software just to move the teeth together, and I can check real quickly digitally to see if the occlusion is good, rather than having to wait on alginate impressions to dry up, hold the cast together, and see what we need to do. Well, with the aligners and with the VPRO 5, the teeth tracked perfectly, and just after 33 months or 90 days of treatment, he's ready to get the jaw surgery. So what we do is this is post-surgery, we put hooks on the teeth up here, and he's to do the jaw surgery and have his aligners cut around it. Well, this is when he comes to me after jaw surgery. The surgeon made a bit of a mistake. He was supposed to tell the patient to wear the aligners, and I told the patient to wear the aligners, but the patient was asleep, the doctor didn't put the aligners in, and he just started wearing the elastics without the aligners. So he comes back to see me, and the occlusion is great, or closer. We got a little bit of a class 2 problem, but you can see the effect of this wearing the elastics without the effects of wearing the elastics without the aligners in, lots of extrusions. No problem, because now we've got the wrap response from the surgery and the VPRO 5 to help us out. And so here we're going to do a scan, we're going to make him some retainers, and then we're going to have Invisalign virtually remove all these attachments. Well, we just get 10 aligners for our final clean check, just to line up those teeth. We're going to use the VPRO 5. And so he comes back after those aligners, and here's the final results. 10 refinement aligners after the surgery. And so we had 7 weeks of refinement, 5 days per aligner, 8 months total treatment time, 5 months of active treatment time. So we had about 3 months before surgery, 2 months of Invisalign after surgery, and then about 3 months in between, where we were waiting on the surgery and waiting on him to heal. So a very nice surgical result case using the VPRO 5 to get us to the surgery more predictably at 5-day aligner changes, because the VPRO 5 helped seat the aligners better, and so we didn't have to do a refinement, and we were able to get the surgery done sooner. And then we used the VPRO 5 to help seat the aligners better during the refinement stage after the surgery, and he got just a great result. You can see his before and after occlusion here, and his profile is nice and straight. This is so soon after the surgery. He's still a little bit swollen. This was just a couple months ago. He's at school. He's going to come see me over Christmas break, and we'll see how stable he looks, because now he's in Vibera. One last case, and then we'll finish up. We'll throw in a little carrier motion here. So here's a unilateral class 2, class 1 on the left, class 2 on the right. We can see the upper midline shift. And so we're going to use carrier motion on him in order to correct that class 2, then Invisalign. But it looks like he's missing a third bicuspid, and this second bicuspid is like coming in. Well, this is why I like to use CBCT, because this is what the pano would have looked like. This is what the image looks like on the CBCT. And I can see the true reason why that second molar isn't erupting is because the third molar is forming behind it and over top of it, preventing it from erupting in. So people can't tell me that CBCT doesn't have any value in the everyday practice. Almost every case I find something using the CBCT that enhances my treatment plan, and this is one of them, because now I know I don't have to wait on the second molar to come in, but to start treatment, because it's going to take a while. So I'm going to order the extraction of the third molar, go ahead and get started with treatment, and then this might come in a year or so, and if it comes in crooked, I can throw a few braces on the side to line it up. But he wants to get his treatment done, so we're not going to be waiting on that to get started. Turns out he never did have this done, so I'm still waiting on him to have that wisdom tooth extracted. Look at the airway, look at the proclination of the upper incisors. So this is 2.5 months with the carrier motion. We can see that the midline was off to the left. Now it's closer to center. We've got the left side super class 1. On the right side, we've got it corrected to a class 1, and we're able to do that in just 2.5 months using the carrier motion. So now this becomes a much easier ClinCheck for us. I very often see an increase in the airway by using the carrier motion because of the traction on the lower jaw. We can see that the airway increased. I've got a little pilot study going where we show that we've been able to consistently increase the airway using the carrier motion, but that's not ready for publication yet. So that's just some of my initial thoughts and something that I'm working on. So now we took that difficult unilateral Invisalign ClinCheck and we made it an 18-tray ClinCheck using the carrier motion in order to get us into class 1 first. Now instead of having 40, 45, 50 aligners and some asymmetric IPR and asymmetric elastics, now it's a super easy 18-tray ClinCheck just to close the upper space. So here's the initial ClinCheck images. Here's the final ClinCheck look. And again, those same images. And here we are using the vPro 5. So we use the vPro 5 to change the aligners every 5 days. And those 18 aligners, we were able to finish those aligners in just 3.5 months. So 4.5 months Invisalign. Why 4.5 months? Well, we had a month just waiting on the aligners to come back from the lab. So it was actually 3.5 months of actual movement, but I'm counting 4.5 months for the entire Invisalign process. So 2.5 months for carrier motion, 4.5 for Invisalign, and here's the final results on that unilateral class 2, 7 months total treatment time. So we took a very moderately difficult case using vPro 5, changing the aligners every 5 days, using the carrier motion, all these little tools and tricks in order to give great care to our patients in the most efficient time as possible. Anyway, so that's going to be the end of the presentation for tonight. I hope you got some useful information out of that, some more difficult cases. If any of you have any cases you want to share with the group, join Acceleration Ortho Station, post your successes, post your questions, post your failures. Everything's fair game. Let's talk about it as a group, and I will go ahead and start taking some questions. No one's asked any questions yet, so I'm going to open the question pane, and oh, I do see some questions here, so let me try and get the questions brought out here so I can read them better. One question, and I'll stick around for a few minutes to answer questions. So here's the question. It is possible or recommended to use the vPro 5 more than one time a day is the question mark, is the question. So the question is, can you use it more than one time a day? Well, my understanding is that the recommendation from Propel is to use it one time per day. That's all that I ask the patients to do, it is just one time a day, because I want to give them a slam dunk. If I ask the patient to wear a liner seater 20 minutes a day or 3 times a day or 4 times a day, they have a hard time finding that much time during the day, and so because they fell a little bit, they end up not doing it at all. So I want to give them a slam dunk and make it real easy and say just do it one time a day. And the reason why I tell them one time a day and I have them do it at night because that's when they're going to be wearing their aligners the longest. We want to fully seat it before they go to bed. Now, if the patient comes to me and they say, well, it feels really good, because a lot of the patients will come to me and say, well, I have a decrease in pain when I'm using it. Can I do it more often? I say, absolutely you can. I say, use it 3 or 4 times a day if you want to. They've already exceeded the 1 time a day, and in my opinion, it's fine for them to use it 3 or 4 times a day to help seat the aligners, but I don't require it. From a patient management standpoint, I require it 1 time a day. If they want to use it 3 or 4 times a day, that's fine with me. All right, any other questions? All right, my buddy, Jason. Glad to hear from you, Jason. He says, hey bro, great presentation. Would you suggest MOPs plus motion for even faster movement? Absolutely, I would. So I do some presentations on how to use the carrier motion with the MOPs. I think I showed how I did that in June or July of 2016, so a year and a half ago. You can ask your rep, and they can show you some carrier motion cases with MOPs. And if you really want to see some great cases, sign up for the Henry Schein Orthodontic Symposium in Scottsdale, and I'm going to do at least 20 or 30 minutes and at least 5 or 6 cases using MOPs with carrier motion. But the bottom line is I get great results on MOPs, on carrier motion with MOPs. I put 2 perforations distal of the posterior teeth on the top. So 2 distal of the 3, 2 distal of the 4, the 5, the 6, and the 7 during the distalization process. I do this in the adults because those are the ones that need a little bit of a ramp up to help get a little bit better results. And I've seen some real predictable movements with that. Daniel says, thanks, great webinar. With the Propel Power, Keith says, with the Propel Power Tip, do you find mucosal tissue winds? What do you do to prevent it? So let me see if I can escape out of here to answer your question with a slide, Keith. So let's get back to this slide right here. And I hope that transition showed up on your screen. Okay, so when we're doing 2 perforations, one of the things that we find is when we get very thin mucosa, in these areas back here, the tissue starts to wind around the screw if the tissue is really thin. So what do I do? Well, I'm going along good. Oh, tissue starting to wind around the screw. So when I see the tissue starting to wind around the screw, I don't just push forward, because a lot of times you can get a tear in the tissue, sometimes even about this big. So it's not recommended to just kind of keep going and maybe you can get it to drive in. As soon as you see that tissue winding around the screw, you want to stop the power driver and reverse out. And then you want to fix the problem, okay? So I may reposition the screw just a little bit and then go back in. But this time I'm going to be using my finger to pull the tissue really tight in order to keep the tissue from winding around the screw. Another trick that I've used is that wooden Q-tip that we no longer use for topical. It still has a use. What I'll use is, because sometimes back in this area it's hard to get our big fingers back far enough to stretch that tissue. So what I'll do is I'll push the Q-tip between the screw and the soft tissue, right up against the screw. And so if the screw is going clockwise, I actually want to put a counterclockwise pressure with the Q-tip against the screw. So as I'm pushing right here counterclockwise against the screw, that can help the tissue from winding clockwise. So again, the screw's going clockwise, the tissue wants to grind clockwise, so the wooden Q-tip pointed this direction down in a counterclockwise direction can sometimes help prevent that tissue from winding. Now, if you do all that and the tissue is still winding around, then you want to just give up, okay? So then what I would do is, we've already got one here. When we go to the next area, instead of trying to do two right here, I'm only going to place one right at the mucogingival junction a little bit lower. Because if the tissue is winding here, it's only going to be worse in this area right here. So Keith, I hope that that answered your question on my approach to keep the tissue from winding. Jason Kaplan says, nice plug. I think that's in response to the HSO seminar. Yes, I will be speaking in February in Scottsdale, HSO seminar on carrier motion, on some airway stuff with carrier motion, and on vPro 5. All right. Keith says, thanks. So I've got nothing but thanks. So thank you guys, everyone. I'll talk a little bit for 30 seconds to see if there's any more questions. I'll throw another plug up for my acceleration ortho station. We'll get that slide back up while I'm waiting on any last questions. Okay, hey, you guys have done really good. Most of the people that started are still here, and we're at the hour-and-a-half mark, so I'm honored by your attendance. The acceleration ortho station is only for orthodontics and orthodontic residents. I do have someone vetting those people, so it's only for the orthodontists. All right. Any last questions before we call it quits tonight? All right. Thank you very much for your time. I really appreciate you being here. Propel has changed my life and my practice, so that's why I'm happy to talk so much about it. There's a lot of great clinical cases on this. I've seen a lot of nice work for people, from people. I've seen some nice research on this. The research is only getting better. So thank you all for your attendance, and Merry Christmas, Happy Holidays to you all. Happy Hanukkah to my Jewish friends. All those nice things. Happy Holidays to everyone, and Merry Christmas. I'll see you in Scottsdale, Paul. Have a good night. Bye-bye.